Hello, welcome to the lecture. My name is Jaspreet and I'm a second year's master's student. Today, the topic of discussion is the blood transfusion. So the learning outcome for this lecture is at the end of the presentation, we will be familiar with the different blood components and why we need to administer them, how we administer, and the nursing responsibilities when we administer them, along with the complications. So blood component therapy, it may be transfused as a whole blood or as one of its components because patients seldom require all the components of a whole blood. It makes sense to transfuse only that portion needed by the patient for a specific condition or disease. So this treatment is known as a blood component therapy. So there are four main components of a blood, which include red blood cells, plasma, platelets, and cryoprecipitates. Red blood cells, also known as erythrocytes, which deliver oxygen to the tissues in your body. Plasma is a clear, straw-colored liquid portion of a blood that remains after red blood cells, white cells, platelets, and other cellular components are removed. It is the single largest component of a human blood, comprising about 55% and contains water, salt, enzymes, antibodies, and other proteins. Whereas platelets are also known as thrombocytes, are the colorless blood cells that help blood clot. Platelets stop bleeding by clumping and forming plugs in the blood and vessel injuries. Cryoprecipitate antihemophilic factor is also called a cryo. It is a portion of a plasma and the liquid part of your blood. Cryo is rich in a clotting factor, which are proteins that can reduce blood loss by helping to slow or stop bleeding. The blood clotting proteins found in the cryo include a fibrinogen, factor 8, factor 13, or von Willebrand factor. Next, we're going to talk about ABO groups. So there are four main blood groups or the types of the blood, A, B, AB, and O. So your blood group is determined by the genes you inherit from your parents, and your blood group is identified by the antibodies and antigens present in your blood. Antibodies are proteins found in the plasma, whereas they are the part of your body's natural defense. They recognize foreign substance such as germs and alert your immune system. Whereas antigens are protein molecules found on the surface of red blood cells. So group O has no antigen, but both anti-A and anti-B bodies in the plasma. Whereas group A has A antigen on the red blood cells and anti-B bodies in the plasma. Group B has B antigen with anti-A in the plasma. Blood group AB has both A and B antigens, but does not have any antibodies in it. Next is each group can be either Rh positive or Rh negative, so which means in total there are 8 groups. So Rh or rhesus factor is an inherited protein found on the surface of red blood cells. If your blood has a protein, you are Rh positive. If your blood lacks a protein, you are Rh negative. So this table explains, based on your blood group, to whom you can donate or receive blood from. So like receiving blood from the wrong ABO group can be life-threatening. For example, if someone with the group B is given group A blood, their anti-A bodies will attack the group A cells. This is why A group never be given to someone who has a group B blood and vice versa. As a group O red cells do not have any A or B antigens, it can be safely given to any other groups. So these are some, these tables show the ABO groups and their compatibility. Next, now we have discussed the now we're going to discuss the indications and the key considerations while administering different blood components one by one. First is the RBCs, red blood cells. In the clinical, you will hear packed red blood cells. So these are used to treat the hemorrhage and to improve oxygen delivery to the tissues. Transfusion of red cells should be based on the patient's clinical condition. Indications for the transfusion include symptomatic anemia, acute sickle cell crisis, or acute blood loss of more than 30% of the blood volume. So 1 unit of a packed cells should increase level of a hemoglobin by 10 gram per liter and hematocrit by 3%. And the normally the volume of the bag is approximately 250 ml, but may vary at the times. There are some key considerations while administering packed red cells. So use an IV catheter suitable for the size of the vein and a purpose of a transfusion. The catheter could be anywhere from 22 to 14 gauge, but most commonly used size is 20 to 18 gauge for the general population. Administered through a standard blood transfusion set that has a micron filter of 170 to 260. And air eliminating micron filters are not compatible with the RBC transfusions. And you need to change a set as needed at a minimum at every 8 hours, or unless your set is soiled or contaminated. RBC may be infused using a blood warmer, pressure infusion device, or syringe pump as ordered by the authorized prescriber or as defined by an approved protocol. Blood warmers or the transfusion pressure transfusion devices are used in ICU or in any emergent conditions. Rapid infusers and other pressure infusion device must not exceed 300 millimeter of mercury, and the only compatible solution with the blood is sodium, normal saline. And blood components should be administered 1 unit at a time. However, in emergency situation, you may need to administer ABO compatible platelets, plasma, or albumin as per physician's discretion. Next is the platelets. So the indications for platelet administration is usually prevention or treatment of a bleeding due to platelet deficiency or dysfunction. The decision to transfuse platelets depends on several factors besides the platelet count. Clinical judgment must be exercised when applying the following guidelines to a specific clinical situation. Like if you want to control bleeding in a platelet deficiency, patient has a thrombocytopenia, patient is hemorrhaging with a platelet count less than 50,000, patient is going for surgery with a platelet count less than 100,000, or in a non-bleeding patients which is rapidly dropping platelet and it is less than 15,000. So there are some key guidelines while administering. The rate should be specified by the most responsible healthcare professionals after patient's assessment, which usually depends on the patient's blood volume, cardiac status, and hemodynamic condition. So recommended infusion time is over 30 to 60 minutes per dose. 1 dose of a donor platelet should raise the platelet count by 5,000 to 10,000, and administer a platelet using the same standard blood transfusion set and make sure the platelets are RH compatible. Next is plasma or the fresh frozen plasma indications. So plasma is available as a frozen plasma, and apheresis fresh frozen plasma. Plasma is a liquid part of a blood, as we discussed earlier. It contains water, minerals, and other substances, whereas FFP is a plasma that has been frozen, so it can be stored maybe for up to 1 year and used later. The plasma you get is a thawed and warm before it is used. So you need to inform the blood bank that you need a plasma. It is prepared from a whole blood separating and freezing plasma within 8 hours of a collection. So typical volume is 200 to 250 ml, but it does not provide any platelets or red blood cells. So you do not need this to be RH compatible. And the indications are treatment or prevention of clinically significant bleeding due to a deficiency of one or more plasma coagulation factors, for which more appropriate or specific alternative therapy is not available. Patients who are bleeding or undergoing invasive procedures who require replacement of a multiple plasma coagulation factors, patient with a massive hemorrhage with a clinically significant coagulation abnormalities, patient with a thrombotic thrombocytic purpura, hemolytic uremic syndrome, or other condition treated by therapeutic plasma exchange, where the exchange fluid must contain coagulation factors. Next is a cryoprecipitate. Cryoprecipitate is prepared from slowly thawed frozen plasma that has been centrifuged to separate the insoluble cryoprecipitate from the plasma. The insoluble cryoprecipitate is refrozen with the volume of each unit 5 to 15 ml. Also contain coagulation factors 8, 13, 1-Billeren factor, and fibronectin. And the indications include it's usually given to the patients with the low fibrinogen levels, prophylaxis in acute promyelocytic leukemia or a chemotherapy, or if the patient has a fibrinogen level less than 1.5 gram per liter, or sometimes in obstetrical hemorrhage or cardiovascular surgery if they have fibrinogen level in less than a 2.0 gram. And the most common recommended dose is 1 unit per 10 kilo. So along with this, there are some other blood products like albumin, which is used to treat or prevent shock following serious injury, bleeding, burns, to increase the volume of a blood plasma. This can also replace low blood protein. Factors like factor 8, 13, 9 concentration, or antithrombin 3 concentrate as well, if the patient is deficient in any of these factors. Intravenous immunoglobulin can be given. It's also called IVIGs. These are administered when patients have immunodeficiency or specific antibodies deficiency. Hepatitis B immunoglobulins are given if patient has accidental exposure to hepatitis B. Varicella zoster immunoglobulins are usually indicated for the newborns of the mothers who develop chickenpox within 5 days before and 48 hours after the delivery. Next is a prothrombin complex concentrates are used in emergent conditions to reverse the warfarin-induced anticoagulation with a major bleeding. So this is the end of the first part. Now we know the indications and key considerations for different blood products. It is time to infuse now. But before we infuse, we need to assess this patient. Assessment prior to transfusion includes check the vital signs to get a baseline. Assess patient's lungs and kidney. Are the lungs clear? Are there any crackles? Or if they have an adequate renal function? Check the lab values, which include GFR, that is the glomerular filtration rate, to check the kidney function, creatinine levels, and check the hemoglobin levels. So you also need to take a patient's history of a transfusion, ask patient if they had a transfusion reaction in the past, or if there are any close family, like their parents or their siblings, had a transfusion reaction. Next is there are some steps how to transfuse. First and foremost, check order and check if the patient is cross-matched, and make sure the patient has a written informed consent has been obtained, and confirm the patient is wearing a transfusion service identification number. It used to be called as a BB number when required, and if it is still valid. Gather required equipment, obtain and verify blood components or a product. You have to go to the blood bank to get it. Um, have a second healthcare professional to verify the patient's identity and blood components or the blood products. Make sure you complete the pre-transfusion assessment. Advise the patient to report any side effects when possible, and administer the blood components. Monitor the transfusion as per hospital policy. Report any adverse reaction and complete the documentation. So next is consent. So this is the most important part. You cannot administer unless until you have a written consent from the patient. So most responsible healthcare practitioners need to obtain a written consent prior to blood transfusion and should be documented in the chart. So you can be a witness to consent, but cannot get a written consent signed by a patient. The next is how long does this consent is valid for? The consent is required whenever the patient is receiving a transfusion first time when in a hospital. So for an inpatient consent, a consent form is valid for one admission or unless patient revokes the consent. In an outpatient settings, the consent form is valid for the duration of a planned treatment up to 1 year after signature. An outpatient consent for blood is not valid for an inpatient admission. For example, if the patient is going for a surgery in 3 months, so doctor can obtain a consent in their office as an outpatient, and when patient goes to the operating room or are going to get any treatment, if they need, they can be transfused. Completed consent forms are placed in the medical record, and it may be prudent to routinely renew all consent after the first of each year. Next is the TSIN, that's a Transfusion Service Identification Number. It's previously known as BBIN number. It is a system that ensures unequivocal identification of a patient's and blood components from vein to vein. This means it ensures a traceable connection from the patient's pre-transfusion type and screening sample through testing in the transfusion lab and through the transfusion of cross-matched blood cells. The new provincial TSIN system allows for the standardization of the system across the province, sports bedside and laboratory connect care workflows, and will eventually support the ability to provide transfusion services across the zone. So when you're administering, first you need to do is check the order. So what an order should include? So the order must include the type of a blood product to be administered. Does the patient need an albumin? Does the patient need an packed red cells? And dosage, or like how many units? Does the patient need 1 unit, 2 units, or more than that? And the duration over the how long over what time period the unit should be administered. If there is a no duration, then you would follow the hospital care policy. And what's the frequency? Do you want it to administer once or twice or every other day? Or if there's any pre or post lab test that's ordered, or if there's any medication ordered in between, before or after the transfusion. So for equipment, you need a dedicated blood transfusion set, normal saline, gloves, and 2 healthcare professionals, and a blood product. So you need to, it is important, pick only 1 unit at a time and sign for blood checking, name identification, number of a patient, transfusion donor number, expiration date of a component, ABO, and RH compatibility in the patient. Next, there are some checks that you need to do with the 2 healthcare providers. So this is an important verification that prevents the complications of the transfusion reaction. The healthcare professional who is administering the transfusion must verify with a second nursing professional using verbal check. The blood component received is consistent with the transfusion order, means you compare your blood with the order, and the blood component or product is not expired. The healthcare professional who is administering the transfusion must read aloud and spell out the following, while the second healthcare professional visually confirms that the information is correct and matches the patient identification documentation and the transfusion bag in the presence of a patient. So first is a patient's name, first and last name, then patient's unique identifier, that could be ULI or healthcare number, the TSIN band. It should match the TSIN number on the transfusion bag if it's present, because sometimes TSIN is not required for platelets or cryoprecipitates. However, if the TSN is present on the transfusion bag, then it must match the TSN band. The TSN match may not be available in unmatched units. Being said that sometimes we need to transfuse unmatched blood in emergency conditions when there's no time to cross-match. The majority of the time it is done in ICU or in the emergency or in the OR. And the most common type of unmatched blood is used as an O negative. Next is the unit identification number or lot number on the blood component. It should match the unit identification on the transfusion bag. The ABORH group on the blood component transfusion tag matches the blood component label. Sometimes plasma and cryoprecipitate labels do not include RH factor. That is okay. The ABO-RH group of the blood component is compatible with the patient's ABO-RH group. If a discrepancy is found at any time during the verification process, you need to stop the process and contact the blood bank to resolve this discrepancy. So following the verification process, the healthcare professional who is administering the transfusion must sign the transfusion documentation and have the second healthcare professional or healthcare provider confirming verification also sign the transfusion documentation. So I cannot emphasize enough on the patient assessment when you are doing any procedure. So first we start with the vital signs. We will get in a baseline vital signs before you start the transfusion. Then you need to do the vital sign 15 minutes after the initiation, and then every 1 hour for the duration of a transfusion, and once post-transfusion. Once your transfusion is finished, you will do the vital signs. So one healthcare professional must remain at the patient's bedside for the first 5 minutes and remaining immediately available for the 15 minutes of the transfusion, because most of the transfusion reactions happen in first 5 to 15 minutes of the transfusion. After the 15 minutes, one healthcare professional must remain within the patient's care area, which means the person should be able to respond to a call bell immediately. So next is the administration and discontinuation part. So you will prime the blood transfusion set with a normal saline, and then you would hang blood. Make sure the normal saline is turned off and the blood port is open, and then you will initiate the transfusion slowly for the first 15 minutes at 1 ml per hour, because majority of the transfusion reactions occur in the 15 minutes. When you discontinue, you need to flush the line to ensure all blood is cleared from the line at the same rate of the blood transfusion. Take patient's vital signs. There's usually a tag that you use to identify the patient attached to the blood unit. So that needs to stay attached with the blood. So finish the documentation. Bag and tubing are discarded in a biohazard container if you do not require a second unit. If you need a second unit, make sure you keep the vein open by infusing normal saline. Sometimes you might need to change in equipment, but same set can be used for the second unit if transfusing within 8 hours. But if there's any contamination, you might need to use a second set, and you do not need second nurse when discontinuing. Next is the transfusion reaction. So when managing blood transfusions, it is important to prevent complications from occurring and to identify issues promptly to manage reactions effectively. Transfusion reactions may occur despite all the safety measures taken. All transfusion reactions and transfusion errors must be reported to the hospital transfusion services, that is blood bank. So these reactions may vary from the mild reactions to the life-threatening. So the sign and symptoms under the cutaneous include the patient might show have a pruritus, urticaria, arrhythmia, flushing, jaundice, pallor, cyanosis, petechiae, or purpura. And in an inflammatory, a patient may show fever, chills, or rigors. And in a cardiovascular system, the patient may be tachycardic, bradycardic, hypotensive, or hypertensive, maybe having arrhythmia, shock, or the jugular vein distension. Respiratory, patient might have a tachypneic, dyspneic, presence of a wheezing, rales, hoarseness, stridor, pulmonary edema, or a chest tightness, whereas nausea, vomiting, and diarrhea in the gastrointestinal system. And patient may complain headache, chest pain, substernal pain, abdominal or back pain, or pain at the infusion site, or pain in the proximal extremities. So any reaction or any symptom that patient report, you need to further investigate if this symptom is because of the blood transfusion, is part of the blood transfusion reaction, or is it a patient's normal? So when you transfuse, it is important to have certain things ready. That's called emergency equipment. First and foremost, you need to know where the crash cart is. You have to know that where your crash cart is, and have an oxygen tube close by, or the mask and you have a suction, and make sure you have a normal saline line primed if you need to, if the patient shows any sign of reaction, you need to start normal saline. And some emergency medications may include diamond hydrogenate if the patient is showing any allergic reaction. Diamond hydrogenate for any of the nausea, vomiting, diamond hydramine for any allergic reaction, hydrocortisone or epinephrine for any life-threatening conditions. So complications associated with the blood component therapy could be acute. It could be acute hemolytic or non-hemolytic reactions. So acute hemolytic transfusion, it is a serious complication that can occur within 5 to 15 minutes of initiation of a transfusion and may cause death if not treated immediately. The reaction occurs when the red blood cells were given during a transfusion are destroyed by the person's immune system, and this process is called hemolysis. So if a person receives a blood that is not compatible with their own blood, the body will produce antibodies to destroy the donor's blood cells, causing hemolysis. Disseminated intravascular coagulation is one of the life-threatening symptoms of acute hemolytic transfusion reaction, in which the protein that controls blood clotting becomes overactive. The non-hemolytic transfusion reactions, they're usually fever, which are usually caused by the cytokines from leukocytes in transfused red cells or platelet components, causing fever, chills, or rigors. In the transfusion setting, a fever is defined as a temperature elevation of 1 degree or centigrade or 2 degree Fahrenheit from the baseline within the 4 hours of administration. So you, as I mentioned previously, you need a baseline vital signs to compare if the patient is showing any complications of transfusion. So in a febrile reaction, the antibodies in the blood react to leukocytes, which may lead to the fever, chills, and a headache. The first treatment is to stop the transfusion and then notify the physician and let the normal saline run. And a physician might order you to give some antipyretic for the fever. Then the allergic reactions, so sometimes immune system from the antibodies against the plasma protein, despite the same blood group, leading to allergic reaction. It may exhibit signs and symptoms of a hives, itching, or respiratory distress. So if you notice any sign or symptoms of an allergic reaction, I cannot emphasize enough to quickly stop the transfusion and inform. So sometimes if the reaction is mild, if the patient has a mild fever or a mild allergic reaction, a physician may order to continue the infusion after the administration of antipyretic or antihistamine administration, but it is up to the physician to take that decision. Next, there are some delayed complications of a transfusion reactions. So the first one is transfusion-related acute lung injury toxicity. It is an infrequent but serious complication that occurs within hours following the transfusion of a blood product. And it is characterized by respiratory distress, hypoxemia, pulmonary edema, hypertension, and fever. There is a circulatory overload, which is a common transfusion reaction in which pulmonary edema develops primarily due to volume excess or a circulatory overload. So that is why sometimes you might see Lasix odor after the transfusion or in between the 2 units. Next is the citrate toxicity. Citrate toxicity results when the citrate in the transfused blood begins to bind calcium in the patient's body, causing hypocalcemia. Clinically significant hypoglycemia does not usually occur unless the rate of transfusion exceeds 1 unit every 5 minutes. So if the patient is under massive transfusion protocol, they have to be careful. You have to be careful of the citrate toxicity. Then there is a transfusion-associated graft versus host disease. So it is a very rare but fatal complication of a blood transfusion in which the lymphocytes from the transfused blood component attack the recipient's tissue, especially the skin, bone marrow, and the GI tract. And next is the delayed hemolytic transfusion reaction. So it is a red blood cell hemolysis. It occurs anywhere from 2 to 21 days after the transfusion. The patient usually present with the unexplained anemia, low-grade fever, jaundice, or worsening renal function. So there is some nursing responsibilities associated with this. So if transfusion reaction occurs, you need to stop the transfusion and start an IV line with normal saline. Place the client in follower's position if the shortness of a breath and administer oxygen therapy. The nurse should remain with the client observing any worsening or the new sign and symptoms and monitor vital signs every 5 minutes. You need to notify the physician immediately. The nurse prepared to administer emergency drugs such as antihistamines, vasopressors, fluids, steroids, epinephrine, as per a physician's order, or sometimes there is a standard protocol. So you need to obtain a urine specimen and send it to lab to determine the presence of a hemoglobin as a result of our hemoglobin red blood cells hemolysis. And the blood container, the bag, tubing, attached label, and transfusion record should be saved and returned to the lab for analysis, because sometimes they need to analyze why this reaction had occurred. So as we talked, that there could be a delayed hemolytic transfusion reaction can occur somewhere between 2 to 21 days. So if your patient is getting discharged, or if the patient is getting an outpatient blood transfusion, you need to educate the patient that there could be an delayed transfuse reaction, or what signs and symptoms of the transfusion reaction they need to monitor. So there are some infection-related complications as well. These are called transfusion transmitted diseases. So blood products, it works through 3 mechanisms. First, transfusion of a microbes present in asymptomatic donor. It's usually viruses. It could be HIV, Hep B, or Hep C. Contamination of a stored blood products. It's usually presence of a bacteria in the platelets, and transfusion related immunosuppression, which predispose the patient to the infection and others. And the risk of infection increases with the amount of red blood cells or blood products transfused, and patient requiring chronic blood or products make them most vulnerable. So more you need a blood transfusions, more vulnerable are you to the infection. A wide variety of organisms, including viruses, cytomegalovirus, bacteria, prions, or parasitic infections, or like a West Nile virus can be transmitted through blood transfusion. The use of a standard donor screening questionnaire as well as a lab test help to reduce the risk of an infectious organisms being transmitted by the blood transfusion. So when you administer blood or blood components, there are some key points. First of all, you need to know why your patient is receiving their blood product. What are the indications? So is your patient anemic? Is your patient is going for OR? Is your patient is actively bleeding? And then you need to know the guidelines regarding that specific product. What are the guidelines for the packed red bloods? What is the guidelines for albumin? What are the guidelines for IVIGs? So you need to make yourself aware of the policy and procedures. If you do not know, there are in the clinical, most of the time you can access them, or ask your nurses where you can access, or your instructor. Patient's education. It is the key for the early identification. So make sure you educate your patient what signs and symptoms they should report immediately as soon as they occur. So you need to be ready for any transfusion reaction. Like I talked about, there should be an emergency equipment, and stay with the patient for the first 15 minutes. And we have talked throughout all the procedures: assess, assess, and assess, because early recognition of a transfusion reaction can prevent the complications. And documentation is important part when you are doing a blood transfusion blood transfusion. It comes with an transfusion document that is attached to the blood unit. Doesn't matter it's a plasma or a platelets. So during the administration, that piece of a paper should stay attached to the your product. And once it's a transfusion is complete, you complete the document and you send it back to the lab, and one part stays in the patient's chart. And because no documentation, and it means nothing is done. That is the end of the presentation. Thank you for listening. And there are some resources available in the e-class. Please check that. And I cannot emphasize enough to complete your knowledge checks. It will be available starting Friday. And I have attached the application scenarios. So if you can go through, because sometimes you may encounter those scenarios in your clinicals. Thank you.